transmitted infections. So by definition, genital ulcer is any breach in continuity of skin and mucosa or skin in genital area. So the genital ulcers caused by STI includes herpes simplex virus 1 and 2, Treponema pallidum species causing primary syphilis, Haemophilus ducreyi causing chancroid, Chlamydia trachomatis serotype L1, L2 and L3 causing LGB, Klebsiella granulomatosis causing granuloma inguinal. Approach to ulcer includes 3 types of approach, where traditional clinical approach, physician analyze symptoms of the patient and come to a diagnosis and treat accordingly. In lab-assisted approach, physician do lab investigations to confirm the diagnosis and treat accordingly. In syndromic approach, even trained personnel will follow a flow chart in which he'll fit the symptoms of the patient and treat accordingly with the kits. So coming to the first case of presentation, a 30-year male presented with painless ulcer over shaft of the penis and glands since 4 days. He also had burning sensation and dysuria for 4 days and mild fever and malaise. No prior similar episodes were present. He had an unprotected sexual intercourse with new partner 10 days ago. On examination, it revealed multiple ulcers on erythematous base coalescing to form a succinate margin, which was tender on palpation. Zank smear was done from a fresh vesicle, which revealed multiple giant cells and ballooning keratinocytes as shown in first arrow and second arrow. So the diagnosis was genital herpes and he was treated with grade 5. Herpes genitalis was genital herpes is caused by herpes simplex virus 1 and 2, which belongs to alpha herpiviridae family. Coming to the structure, it contains a core which contains double-stranded DNA, which is covered by a capsule, which are made up of capsomeres, and it is icosahedral in shape. And it is followed by a tegument, which is proteinaceous material of virus, and then an envelope which contains multiple glycoproteins. Coming to the pathology, virus enter through defects and then they proliferate and they enter local nerves and undergo retrograde axonal flow, and then the rest at a ganglion, especially trigeminal and sacral ganglion, where they maintain latency by cell-mediated immunity. Whenever the cell-mediated immunity gets decreased, like physical stress, emotional stress or trauma, fever, sunlight, it gets activated and it goes centrifugal migration and cause recurrence. So types of herpes simplex of 1 and 2, they only differ in the glycoprotein G genes. Traditional view is that herpes simplex virus cause above waist infection and 2 cause below waist infection. But current literature from Sweden shows many of the finger and hand infections were caused by herpes simplex virus 2. Mechanism of transmission, human being the only host, mechanism of transmission was direct contact. Pathology of infection is cytopathic degeneration of keratinocytes, which is mainly ballooning degeneration, lead to multiple vacuole formation and edema of the cytoplasm, leading to formation of a balloon cell, which again fuse to form multinucleated giant cell, which have multiple intranuclear inclusion bodies, mainly of Cowdrey A type. So coming to HSV1 infections, most of the infections are acquired during childhood and they are easily transmitted and cause recurrent orofacial infections. So, clinical presentation of herpes simplex can be divided as a primary episode and a recurrent episode. A primary episode can be true primary or non-primary. In true primary, serology of the patient will be negative for herpes simplex of any type. In non-primary, a patient will be serologically positive for herpes simplex virus. In a sexually active individual, 90% of them are unaware that they have herpes simplex virus. Either symptomatic or asymptomatic, with lesions or without lesion, patient can still transmit herpes simplex. Genital transmission is more common in herpes simplex virus 2, and orogenital transmission is more common in herpes simplex 1. The lesion can start as painful papule or a vesicle that will progress to form pustule that will coalesce to form polycyclic ulcer that usually resolve in or more than 3 weeks. Prodromal symptoms can precede the onset of lesion like pain, burning sensation, and even systemic symptoms can be present in the form of fever, myalgia, and a female patient most of the times have cervicitis, which we fail to recognize because of presence of painful genital ulcer. We doesn't attempt the speculum examination. The cervicitis can be either ulcerative or necrotic. In MSM and female patient, proctitis can be a presentation, and pharyngeal lesions can be present. Complications can be varied. It can be CNS complications like meningitis, extragenital lesions can be present, dissemination can occur in immunocompromised patients, and infection. Secondary infection like bacterial or fungal can occur. In special condition like pregnancy, whenever a pregnant patient with symptomatic herpes lesion in last trimester will increase 10% chances of transmitting herpes simplex to the neonate, in which we recommend cesarean section. Neonatal herpes simplex, it can manifest as 3 variants. One is skin, eye and mouth limited, which presents as localized vascular lesions, and they are least severe, or CNS disease like encephalitis, or disseminated disease that will cause disseminated intravascular coagulation and multi-organ dysfunction, and it is life-threatening. In HIV, there can be atypical presentation and long duration of the disease, severe symptoms, and increase in recurrence. Atypical presentation in HIV includes deep progressive ulceration, hemorrhagic, ecthyma, hyperkeratotic varicose lesion resembling condyloma, pseudotumor of tongue, esophagitis, hepatitis, viremia, and dissemination. Investigation includes Zank's smear, histopathology, viral culture, serology, and PCR, which can be done when the lesions are atypical. So coming to procedure of Zank's smear, after explaining the procedure to the patient and taking the consent, the affected area will be cleaned with normal saline rather than any antiseptic, and a sterile blade will be taken where a roof of the vesicle will be removed, and with blunt end of scalpel we scrape the base and we make thin smear out of it, which is led to air dry, and then toluidine solution of 1:10 is put, and it is kept for 1 to 15 minutes, and then it is examined under high power microscope, in which the cytoplasm will be blue and nucleus will be eosinophilic. Other stains which can be used are white stain and methylene blue. Coming to treatment, 3 antivirals are approved, being acyclovir, valcyclovir, and family Both of them, 3 of them are nucleoside reverse transcriptase inhibitors. The dosing is as given. First dosing indicates for primary episode, second dosing is of recurrent episode. In case of resistance to acyclovir, we can give foscarnet, cidofovir, or trifluridine. Suppressive therapy is indicated in frequent recurrences, that is greater than 6 episodes per year, or the one who have severe symptoms, and to reduce transmission to the partners. Coming to my second case, a 33-year-old male presented with multiple painful ulcers over penis, scrotal area, and medial thigh since 3 days, which started at the pustule and ruptured to form ulcers. He also complains of painful inguinal swelling. History of unprotected sexual intercourse with commercial sex worker was present 7 days ago. Coming to the lesion, it contains multiple well-defined non-indurated ulcers with purulent base, which bleeds on manipulation, and the tissue was taken for gram smear that shows multiple cocci bacilli that are arranged linearly, giving a school of fish appearance. So diagnosis would be chancroid. So clinically, chancroid can also be called as soft sore, soft chancre, or ulcus mole. Ulcus meaning ulcer, mole meaning soft. The causative organism is Haemophilus ducreyi, which previously thought to be a Haemophilus bacteria, but currently placed under Actinobacillus of Pastoralaceae. It is a gram-negative Coccobacillus. Risk factor of being following, and then there is significant gender ratio difference. Male is to female ranging from 3:1 to 53:1. It is probably due to most of the times female or asymptomatic, and they heal faster, and they doesn't develop lymphadenitis most of the times, and bubo occurrence will be less in female. Incubation period is 1 to 14 days. Clinical feature: chancroid can start as a painful papule, then progress to form pustule, then multiple foul-smelling ulcers can develop. The ulcer will be have following characteristics. They are usually multiple. The floor contains yellowish purulent exudate and vascular granulation tissue which bleeds on manipulation. Margin would be undermined. Base is non-indurated. Females doesn't have any ulcer, but they can manifest as pain on micturition, defecation, discharge, and dyspareunia. Usually, there is no systemic symptoms in case of chancroid. Extragenital sites can be involved. 60% of the cases with chancroid can develop painful lymphadenitis that further get enlarged, tender, and matted. They undergo separation to form abscess, that is bubo formation, and they can drain on the overlying skin, leading to sinus formation. The sinus can further evolve to form giant chancroid, or it can scar and cause lymphedema, or other complications can occur like phimosis, fistula formation, phagedenic ulcer. The variants of chancroid includes giant chancroid, where a single large chancre is present with peripherally advancing edges, or serpiginous ulcer, or phagedenic ulcer caused by secondary infection by fusor spirochetes, which cause rapidly progressing necrotic ulcer. Transient chancroid, which usually disappear in few days. Follicular chancroid or papillary chancroid, which resembles donovanosis or condyloma lata. Dwarf chancroid, which is usually pustular in nature, mimicking, looking like a pyodoma. Pseudogranuloma inguinal, that looks like a granuloma inguinal, but it doesn't. Coming to the diagnosis, we can do a smear for identification of the bacteria, or Ito Rensterna test, which is an endodermal test where a greater than 1 centimeter diameter would develop in 48 hours is taken as positive. Culture can be done, which is definitive. PCR, indirect immunofluorescence, multiplex PCR, and histopathology can be done. In histopathology, upper zone shows neutrophils, fibrin, RBCs, and necrotic tissue. Middle zone shows proliferation of endothelial blood vessels, and lower zone shows dense infiltrate of plasma cells and lymphoid infiltrate. Coming to treatment, azithromycin, ceftriaxone, cephaloxacin, or erythromycin can be given. Whenever bubo is present, when it is fluctuant, should be aspirated from non-dependent healthy skin before administration of antibiotics. Coming to my case 3, a 29 male present with slowly enlarging painless ulcer over genitalia for 3 weeks. No systemic symptoms were present. History of unprotected sexual intercourse with new partner was present 1 month ago. On examination, large beefy red ulcers with raised and rolled edges was present. Granulation tissue was present, which bleeds easily on touch, and there was no inguinal lymphadenopathy present. And the tissue was taken and it was crushed between 2 slides and stained with gram stain, which revealed multiple intracellular bipolar organism which were resembling safety pin or telephone head appearance. So the diagnosis was donovanosis. Synonyms of donovanosis is as follows. The cause is Klebsiella granulomatosis, also known as Calmetobacterium granulomatosis. It's a gram-negative intracellular bacillus. Clinical features: incubation period is 3 days to 3 months. Single or multiple papules can start to appear, which progress to form painless red beefy granulomatous ulcer, which bleeds on a touch. Along with it, phimosis and lymphedema can also be a presentation. Usually there is no lymph node enlargement. Lesions in the groin are known as pseudobubo, and perianal area can be involved. Hypothesis is that stratified squamous epithelium is actually damaged in donovanosis but not a columnar epithelium. So urethra and rectum are resistant to this disease. Morphological pattern include classic granulomatous, where ulcerating and granulomatous large ulcer will be present. Hypertrophic, where elevated tissue would be present. Sclerotic and cicatricial, where scar tissue would be more evident. Phagedenic type, where extensive tissue necrosis would be seen. In female, phagedenic donovanosis can cause fistula formation leading to rectovaginal fistula and cloaca formation. In males, amputation of penis can occur. Investigation includes stain, biopsy, complement fixation, and PCR. Biopsy can be done to rule out malignancy of long-standing ulcer. Course of the disease are it has very slow progression and no spontaneous healing. In females, pseudoelephantiasis can develop. Stenosis, scar formation, fistula, rectovaginal fistula, epidermal carcinoma are sometimes reported. Male can develop adhesions and deformities of penis. Perinephric abscess and psoas sepsis can develop. Spinal cord compression. Microstomia can present when there are oral lesions. HIV, if present, can cause aggressive ulceration and reduce healing. Coming to treatment, doxycycline or tetracycline or erythromycin can be used. Coming to last case, a 30-year-old male reports with a painless genital ulcer that appeared three weeks ago and healed spontaneously. He now presents with painful swelling in the groin, fever and malaise. History of unprotected intercourse was present 1 month ago. Examination revealed inguinal lymphadenopathy, which is tender and matted lymph nodes, and there is no active genital ulcer. So here on examination, the patient had tender unilateral lymphadenopathy present at the groin. The diagnosis was lymphogranuloma venereum. So it is caused by Chlamydia trachomatis serovirus L1, L2 and L3. It is a gram-negative intracellular obligate bacteria. It is present as extracellular form, which is metabolically inactive, and it is infectious. It is known as elementary body, which one enters into the cell. It enters and form phagocyte, where it becomes metabolically active reticulate bodies, which proliferate and then condense to form elementary bodies, which rupture outside and released into the environment. Synonyms is as follows. Clinical features, incubation period is 3 to 12 days. The clinical features of LGV is divided into 3 stages: primary, inguinal and endorectal stage. A primary stage, which is often transient. Usual manifestation of primary stage is herpetiform, superficial painless evanescent lesion, or there can be an ulcer papule or a nodule. Edema can be present leading to phimosis or paraphimosis. Balanitis, balanoprostatitis, or non-gonococcal urethritis can also be a symptom. Extragenital lesions can be present. Dorsum or shaft of penis can present with linear edema, indicating lymphadenitis of dorsum of penis, known as bullonellus. L2B can cause severe symptomatic proctitis, which is more common in MSM and HIV. Secondary inguinal stage occurs 2 weeks to 6 months after infection. In male, it will start from superior medial group of inguinal lymph node, which then spread to involve entire inguinochloroiliac lymph nodes, and the patient will have so severe pain that he would limp his gait and often bend to relieve his pain. Femoral lymph node, if they are involved, they will be separated from inguinal lymph node by Puppert's ligament. The sign is known as groove of Greenblatt. In female, often deep iliac lymph nodes and perirectal lymph nodes are involved. The presentation will be as lower abdominal pain, mimicking tubo-ovarian abscess or appendicitis. which may progress to form involve the pelvis, and multiple adhesions will be formed leading to frozen pelvis. If bilateral inguinal lymph nodes are involved, it will lead to genital elephantiasis. Systemic disseminations can be present and constitutional symptoms can be present. This is growth sign of green bar. Coming to last stage, genito-anorectal symptom, where the patient can has proctocolitis, lymphoroids can be present, where there is enlargement of lining lymphoid tissue. Early stage of anorectal involvement will present as perianal edema. On examination, there can be pebbled anorectal mucosa. Stricture can be developed. Most common is annular stricture followed by tubular and funnel-like. Complications include genital elephantiasis in male giving to ram horn penis or sexophile penis. In female counterpart, it is known as esthesiomine. And rarely it can also develop carcinoma of rectum. A typical presentation of LGV or papular growth, ureterogenitoperineal syndrome, generalized maculopapular eruption, erythema multiforme, erythema nodosum, unilateral follicular conjunctivitis or episcleritis or keratitis. Culture diagnosis can include culture, microscopy, demonstrating elementary bodies, PCR or immunofluorescence, histopathology which shows a stellate abscess with surrounding granulomatous inflammation, where abscess indicate necrosis, culture and freeze test, barium enema, lymphangiography, CT MRI can be done to find underlying adhesions. Treatment includes doxycycline or erythromycin. So here is a table comparing 4 of them. Thank you.